Welcome to RSSDI TV 2020. I am Dr. Shahu Ingole and you are watching me on RSSDI TV brought to you by Wockhardt. We know that the 80th scientific session, a virtual experience of ADA, happened in June at Chicago. The conference was attended by more than 12,500 delegates from all over the world, including the leading experts in the field of diabetes research. And it had a large number of study groups focusing on the specific aspects of the diabetes and its complication, and some exciting breakthrough research were presented. Hence, to discuss the more highlighted research or presented at ADA 2020, today I am honored to have with me an eminent personality and renowned senior endocrinologist from Hyderabad, Dr. Bipin Sethi sir. Sir is the senior endocrinologist at Care Hospital, Hyderabad. Welcome to the show, sir. So, sir, based on your recent talk in RSSDI, we would like to know what are the new developments in the insulin for the management of type 2 diabetes.
Yeah, that area is something which is developing with some kind of excitement. We know that basal insulins have got a good place in the management of diabetes, and we have moved from NPH to first generation insulins, which was glargine and tetramer. Now the second generation insulins, basal analogs, which is the U300 and degludec. However, these provide at best a control for 1 day. What's exciting that data on EcoDec was presented, which showed good glycemic control with similar degree of safety and hypoglycemic episodes compared, of course, to U100, not U200 or U300 or EcoDec. Sorry, I would like to reframe that. So the data was comparing EcoDec with U100. It would have been exciting to see that compared with U300 or degludec, but the results were essentially that they were grade 2 and grade 3 hypoglycemias were mostly similar, and there were no safety issues. So what is exciting here is that basal insulin is usually delivered once a day now. It would be very nice to have a once a week injection. You already know that we have once a week injectable semaglutide, we have got once in a week injectable dulaglutide. So imagine a type 2 diabetic who has to take just one injection for the entire week. And that will be exciting. Also, in the field of type 1 diabetes, multiple subcutaneous injections with the basal insulin injection are the norm for most people. And if the basal shots can be reduced to once a week, vis-a-vis once daily, then you have 6 injections less. So I think that's very exciting. The data on the oral insulin also was equally good, but not as exciting because their HbA1c falls were not of the magnitude and the kind that one would be liking. But it was shown that once or twice daily, oral insulins were getting your HbA1cs down. For some reason, the third dose did not make any difference to HbA1c. So, lot of good, exciting papers around this. I am more excited about the basal insulin because that is a therapy which is there to stay, which is already in vogue. And if we can reduce the number of shots for type 2 diabetics, it could be quite good. Also for type 1 diabetics, I'm aware that this data which was discussed was on type 2 diabetics, but the trials on type 1 will be soon. What was also interesting, which the researchers wanted to take forward, was they have given about 7 times the dosage of the starting dose of largeness, 70 units of hypodec. They found that hypoglycemia was slightly more in the initial phase. So they feel that maybe 70 units was not such a good dose, and maybe the next trial will be with a smaller dose, and then we might show them some reduction in hypoglycemias. But it'll be exciting to compare that with second generation analogs, the degludec and also U300.
Yeah. So, sir, we know that, sir, SGLT2 inhibitors, they have established place in the management of type 2 diabetes mellitus. So, sir, we will like to know what new data is being generated for the SGLT2 inhibitors.
This is also an exciting area. What has happened is that SGLT2 inhibitors have come a long way from just oral anti-hyperglycemic agents. So what they had done was they had done some kind of data analysis in the AMPLI study, which has been going on for the past 2 years, and they try to compare the outcome specifically of heart failure between GLP-1 based therapies and DPP-4 based therapies, and also reduction in MACE with these agents vis-a-vis GLP-1s and vis-a-vis DPP-4s. So regarding heart failure, there was of course a clear reduction vis-a-vis GLP-1s, which do not have much effect on heart failure, as also DPP-4. But since GLP-1 based therapies have got some reduction in the MACE and all-cause mortality, the difference between SGLT inhibitors and GLP-1 analogs was not reaching significance. However, it did reach significance for MACE and also for the all-cause mortality. For myocardial infarction, they were no better than before inhibitors. And that is one good data that one can be reassuring that what is seen in randomized controlled trials has got very good value. But the only issue is with the numbers and the applicability of data to a population at large, which real world studies really address. The second issue was that of a decline in GFR, the credence. And they found that individuals who have got decline in GFR, when they were substratified into no decline, some decline, and major decline, more than 30%, they found that these people also continue to enjoy the benefits of the canagliflozin therapy in the credence therapy. So, credence trial. So, whether your GFR declines or does not decline does not determine your benefit. More specifically, if your GFR declines, it's not that you will not respond. You're going to have a good benefit with SGLT. So all in all, good news coming for the SGLT inhibitors. You are aware, which is not part of ADA, that there were studies now which show that SGLT inhibitors have got specific role in heart failure, and in CKD we already had this data for canagliflozin for renal failure, then DAPA has data for heart failure as also renal failure. And we also have some data in empagliflozin, so for heart failure. So I think there are good times for SGLT inhibitors if they're used cautiously. One would then derive a glycemic benefit in people who have got preserved GFR, and you will derive at least a organ protection against heart failure and also renal protection. There could be decrease in the MACE if you had a baseline atherosclerotic cardiovascular disease.
So, sir, lastly, we'd like to know from you what are the recent developments as far as the prevention of the diabetes is concerned.
That is also an exciting thing. Thanks for reminding. The DAPA heart failure study had some non-diabetic individuals. Now, these non-diabetic individuals were not necessarily normoglycemic. There were also some subjects who had pre-diabetes. And these pre-diabetic individuals were then randomized to receive placebo or receive 10 milligrams of dapagliflozin. The results of this in terms of prevention of hospitalization of heart failure, mortality, and all that are not relevant to this discussion. But what was found also is that there was a delay in the development of diabetes in individuals who were having pre-diabetes. So I think this is a collateral benefit of a heart failure study. We know that there is published data on lifestyle modifications, metformin, acarbose, also published data on rosiglitazone, which is not relevant for today's discussion, as also pioglitazone and orlistat. We have now new other agent, which was not studied in with the intention of showing the impact in impaired glucose tolerance population, but they found that in heart failure study, when you give dapagliflozin on background therapy, it does prevent diabetes. So you have now the entire spectrum of action for SGLT inhibitors from pre-diabetes to diabetes conversion, at least in the individuals who got heart failure. This is relevant because heart failure patients are more prone to develop diabetes, much like diabetic patients developing heart failure. So if you can prevent one other disease while protecting the person against hospitalization, all-cause mortality, and things like that, I think it's a welcome change, and it's a good study that one has looked at some other collateral benefits. So I think all in all, a good study, and we have another agent which is to be which can be now considered as an agent which prevents diabetes. But how much of it will be used in obese, hypertensive, pre-diabetic individuals? I'm not sure, but I think the temptation would be to use this in that area also, or what with the reduction in the cost for whatever reason of dapagliflozin in laboratory.
Okay. So thank you so much, sir, for sharing your views and joining us on RSSDI TV brought to you by Wockhardt. Thank you so much.
Thank you. Take care.